Hello, this is Girish. I'm going to examine how to demonstrate ankle joint examination. My examination goes in this way. I would like to examine the patient first in the supine position and then also in the standing position. First, I would like to examine the supine position. In supine position, look for the attitude of the leg. It starts with the attitude of the leg. The normal attitude is there's 15 degrees of externation and the patella facing anterolaterally, and the foot is 15 degrees plantar flexed. So normally all the individuals will lie in a 15 degrees of plantar flexion. So in the attitude, you can also see any changes in the attitude, like suppose in cases of foot drop, where the foot is plantar flexed compared to the opposite side, and you can see there is the angle, the 15 degrees angle will be more, so that when compared to the opposite side, it's more flexed, plantar flexed. So that is the attitude. Other things you need to see in the ankle joint is around the malleolus. Coming to the local examination. In the local examination, see for any skin changes around the ankle joint, preferably on the lateral, more commonly on the lateral aspect of the ankle joint, where the talus bursa are very common. Look for any skin changes like sinus, scars, or any signs of inflammation. And also see for any swelling around the lateral malleolus, medial malleolus. In cases of lateral malleolus swelling, in an acute injury, it goes in favor of sprained ankle. The most common ligament to be injured in ankle joint is the anterior clavicular ligament, where you can see the swelling around the anterolateral aspect of the ankle joint. And examining on the medial aspect of the ankle joint, where you can see this diffuse swelling around the medial malleolus. So that indicates medial ligament injury, which is a deltoid ligament, which is in two layers, one is the superficial layer and the deep layer. But it's very difficult to distinguish between the two different layers during the examination. So that's about the inspection. And coming to the palpation. The palpation starts with, before that I would like to examine the patient in standing position. Can you please stand here? Can you lift up your trousers? In standing position, examination from the anterior aspect. In the anterior aspect, look for any deformities in the toes, in the metatarsals, and also see for any flat foot. So if there's a flat foot, all the toes, like there's a loss of arch in the medial aspect, and look for any scars around the pointed toe in the medial aspect, and look for any deformities like Alex valgus or Alex varus, and also look for the deformities in the toes to rule out any hammer toe or hammer toe. And also see from the behind. Can you turn? And from the behind, see for any deformities in the heel, whether the heel is in varus or valgus position. Also, when you see from the back exactly, you should not see any toes. Suppose if the toes are more seen, that indicates there is a varus deformity in the foot. Any right on this? Stop. Palpation. Now coming to the palpation of the ankle joint. For the palpation, first start with any localized temperature. Feel from the dorsum of the ankle and compare with the opposite side. And see for the tenderness around the ankle joint. One is you palpate over the medial malleolus, you palpate over the lateral malleolus, medial malleolus, anterior joint line, posteriorly for the retrocalcaneal bursitis, and also you can palpate for the medial margin of the calcaneum to rule out any plantar fasciitis. So now, and also feel for any tenderness around the metatarsalates, the interphalangeal joints, and palpate. Can you come closer, please? Can you come closer, please? And also palpate around the posterior, the tibialis posterior tendon to rule out any tibialis posterior deficiency in cases of acquired flat foot, and also over the peroneal tendons to rule out peroneal tendinitis on the lateral aspect, and also see for any subluxation of the peroneal tendon in cases of peroneal tendon instability. So there is no instability in this case. So now coming to the special tests, movements of the ankle joint. So the active and passive movements. The active movement the patient himself does can you move your ankle to and fro like this, up and down? So the active movements is fine. Whereas the passive movement where the examiner moves. So the active movement, the passive movement is the dorsal, this is the dorsal flexion, this is the plantar flexion. It's a hinge type of joint. Whereas the other joints, other movements occurring in the foot are the subtalar joint movements. One is the immersion. Examine the immersion. Hold the leg, distal aspect of the leg with one hand and the heel on the other hand. Then turn inwards. So thereby you are moving the subtalar joint. So next, the opposite is you go the other way. This is eversion. And also you can examine the forefoot movements. There is a minimal movement where there is forefoot adduction and abduction. This occurs in the forefoot mid-tarsal joints. And also check for the movements of the metatarsophalangeal joints of all the toes, interphalangeal joints. So all the joints are normal. Next is coming to the special test. In special test, there is a test for instability. In the test for instability, you look for the stability of the ankle joint and the syndesmotic joint. What is for the joint, ankle joint? Lift the leg and hold the distal aspect of the leg in one hand and the other hand the heel. Give an anterior thrust holding the heel. See for any depression around the anterior aspect of the ankle joint. If that is present, then the anterior trois test is positive. That indicates sprained ankle of grade 3. That is more commonly anterior talophumeral ligament is injured. So that is the trois test. To check for the syndesmotic joint, there is a special test called Hopkins test where you compress the distal aspect of the leg so that the patient feels the pain in the anterior aspect of the leg. So that indicates the syndesmotic injury. Other stress tests are there to see for the talar clinically. So that should be done in cases of acute injuries. You need to do with injection of a lidocaine into the joint so that the patient will not experience any pain. In old cases, you can directly do it where the immersion test is, stress test is. So hold the joint, distal aspect of the leg, and the ankle is turned towards the inwards and slightly plantar flexed. Suppose in cases of a chronic anterior talophumeral ligament injury, the patient feels pain inside the attachment of the talophumeral ligament. The eversion test again for the medial ligaments, there is a deltoid ligament. So there is a stress test, and also you need to see for any click sound while doing this test. And other tests are, one is the stress test for Morton's neuroma, where the Morton's neuroma is a neuroma which is interlateral neuroma, which is commonly present in between the third and fourth metatarsal, intermetatarsal space, where you do a squeeze test where the thumb and the index finger is held at the first and the fifth end of the metatarsal and squeezed with the other hand. The thumb and the index finger is placed over the maximum tender point and then feel for the pain. If there is a click, that is called Mudder's click, so that indicates a Mudder's neuroma, and also the patient experiences pain while doing this test. And the conclusion of any joint or any extremity examination should end with a neurological examination. So see for any sensory deficit as well as the motor deficit around the ankle joint. So this ends my ankle joint exam.